Hello, and welcome to the second National Maternal Health Learning and Innovation Symposium. We're so happy to have all of you here today. We're sorry that we can't be in person in Baltimore, but we know that we're going to provide you with high quality, informative sessions and opportunities for networking. My name is Dorothy Cilenti, and I'm here in Chapel Hill, North Carolina at UNC. And I just want to share a little bit about the Maternal Health Learning and Innovation Center, and then we'll start our program. Before we get started, though, I do want to send thoughts to all of you impacted by the hurricane over the weekend, particularly living in Louisiana, Alabama, and Mississippi. We hope that you are doing well and your recovery will be quick. This symposium is offered, as I said, through the Maternal Health Learning and Innovation Center, which is a national resource center that was established shortly before we entered a pandemic with COVID-19 back in late 2019. And we are funded by the Maternal and Child Health Bureau of the Health Resources and Services Administration to accelerate innovative and evidence-informed interventions that will improve maternal health and eliminate maternal health inequities. We, as a partner in this space, seek to harness the momentum of the maternal health movement, and we like to provide a continuum of learning, resources, and partnership opportunities so that we may advance maternal health and facilitate policy changes towards a goal of eliminating inequities. Today, we're thrilled to be joined by public health professionals, healthcare providers, administrators, community groups, people with lived experience, advocates, policymakers, researchers, students, and many others during the symposium. And I'd like to thank our planning committee that's worked so hard to pull this fabulous program together. Our hope is that over the next 2 days, you will hear something that inspires you and innovate and motivates you to be a part of this movement to improve maternal health. But before I go further into our agenda, I would like to turn over the panel to my colleague, Deitre Epps, who is the founder and CEO of Race for Equity, which is one of our important partners in the Maternal Health Learning and Innovation Center. And Deitre is going to take the time to provide us with a call to honor and an important acknowledgement for today. Deitre.
Thank you, Dorothy. Today, as I have been just so aware of the importance of all of us coming together across the country in unity, I'd like to share on behalf of the Maternal Health Learning Innovation Center a call for each of us who is in our individual locations across the country. And this call is a call for acknowledgement and honor. Many of you may have experienced similar acknowledgements and honor in your communities, in your organizations. It is a simple way, but powerful way of showing respect. And doing this, taking this time at the beginning of our 2 days together is a step towards acknowledging the stories and practices of especially around Indigenous people's history and culture. In traveling and doing work abroad, I know that in Australia and in Canada and in other places around the world, it's a common practice towards inviting and honoring the truth of Indigenous people's history and culture. And it's a growing practice and honoring that we're doing it increasingly in the United States. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. So we're going to begin our effort by acknowledging what has been buried and by honoring the truth. So I'll read this acknowledgement and honor out loud. I invite you to read silently along as well. And then when it comes to specific places, I invite you to bring in the thoughts of those, your own community and those around you. Every community owes its existence and vitality to generations from around the world who contributed their hopes, dreams, and energy to making the history that led to this moment. Some were brought here against their will. Some were drawn to leave their distant homes in hope of a better life. Some have lived on this land for more generations than can be counted. We are standing on the ancestral lands of the First Nations people. So wherever you are across the US, there are First Nations people that were here for generations. And we pay respects to their elders, past and present. We honor and pay respect to our ancestors who helped to build this county, the state, and the nation that we live in today. So as we move forward, I'm going to invite you to think about the many legacies from the hundreds of people who are a part of this session on today. And as you think of those legacies, I'm going to share the people who are from where I live. I'm based in Durham, North Carolina. So the example from Durham, North Carolina is shared here. I hope that you also know some of the names of the indigenous people from your communities as well. I am standing on the ancestral lands of the First Nations people, including the Eastern Band of the Cherokee Indians, Kohari, Halawasaponi, Lumbee, Meherrin, Saponi, the Occaneechi Band of the Saponi Nation, and Waccamaw Siouan. We pay respects to their elders, past and present, and we honor and pay respect to all of the ancestors who helped to build all of the locations where you're located. So I'm going to ask us each to take a moment to think about your own legacy and the legacy of everyone that could be a part of this call today. Some have come from a legacy of violence, some of displacement, some of migration or immigration, and also of settlement. And let us consider all of these legacies that bring us together here today as we move forward in advancing maternal health equity across our country. Thank you so much for this time, and we'll just pause for one moment of silence. Thanks again.
Thank you, Deitre. At this time, I'm going to introduce Dr. Michael Warren, who comes to us from the Health Resources and Services Administration. Dr. Warren is the Associate Administrator of the Maternal and Child Health Bureau, which is part of the U.S. Department of Health and Human Services. The mission of the Maternal and Child Health Bureau is to improve the health and well-being of America's mothers, children, and families. The Title V Maternal and Child Health Services Program serves 92% of all pregnant people in this country, 98% of infants, and 60% of all children, including those with special health care needs. Dr. Warren brings to his leadership role experience in the state of Tennessee, where he held many different positions, including Deputy Commissioner for Population Health, Assistant Commissioner for Family Health and Wellness, and the Director of the Maternal and Child Health Title V program. And he's also a graduate of 2 schools in North Carolina, so we consider him family. He did his undergraduate work at Wake Forest University and then his medical training at East Carolina University. So he has family here and comes to visit often. Thank you, Dr. Warren, for bringing some remarks and for your investment in maternal health across the country.
Thank you so much, Dr. Cilenti. It is good to be with you all today. I'm going to share my screen and share a few slides as we are getting started. Thank you for the opportunity to be here. I am joining you from Washington, D.C. today, ancestral home of the Anacostan and Piscataway peoples. And really consider it a pleasure to join you all in this important work today as we think about accelerating improvements in maternal health outcomes. I want to echo Dr. Cilenti's comments at the beginning. Our thoughts and wishes are with our colleagues, particularly those on the Gulf Coast who are experiencing the consequences of Hurricane Ida. And also want to acknowledge the tremendous work that colleagues across the country are doing right now and have been doing for the last year and a half in response to the COVID-19 pandemic. certainly the advent of the Delta variant has created new concerns for folks and really underscored the need for us to think about prevention and mitigation efforts in communities. And we know that many of you and your colleagues are on the front lines. So thank you for that important and difficult work that you are doing. Today, I want to focus on just really celebrating the work that's been done in the maternal health innovation space over the past few years. And when we think about our portfolio related to maternal health in the Bureau, it really covers a spectrum of activities. And much like MCH programs do, we cover the life course. So we have investments, for example, in Bright Futures, the blueprint for well childcare. And someone may say, well, why are you talking about that? This is a maternal health webinar. Well, we know that young children, adolescents, young adults grow up into the populations that we are talking about today. And so if we think about changing those health trajectories, we can't wait until people are pregnant or thinking about getting pregnant. We need to think much earlier in the life course. And so Bright Futures gives us a pathway to do that. Similarly, we have WIPSI, or the Women's Preventive Services Initiative, which is the blueprint for well woman care. So really thinking about where there are opportunities for prevention, preventing disease before it ever happens, preventing those bad outcomes through regular visits, through screenings, and various assessments. We also have programs that are involved in direct service delivery. So our MCV, or Maternal, Infant, and Early Childhood Home Visiting Program, serves children and families in 56 states and jurisdictions. We've got the Healthy Start Initiative, which is located in 101 communities across the country. These are communities with disproportionately high rates of both infant and maternal mortality and other adverse perinatal outcomes. And really, Healthy Start relies on community partners to get at some of the root causes of both infant and maternal health adverse outcomes and disparities in those communities. We've also got efforts focused on improving the quality of care that's delivered to folks across the country. So AIM, the Alliance for Innovation on Maternal Health, works with hospitals and birthing facilities to be able to implement maternal safety bundles focused on a variety of topics aimed at reducing severe maternal morbidity and maternal mortality. And then a newer addition to that portfolio is our AIM Community Care Initiative, where we're trying to take that bundle concept but moving into communities. So if we look at data from our colleagues at CDC, we talk a lot about maternal mortality, pregnancy-related mortality, but if you actually look at when those deaths occur, only about a third occur in the period from labor and delivery to a week postpartum. About a third occur before that, during pregnancy, and about a third occur from a week postpartum all the way to a year out. And so if we're really going to address these pregnancy-related deaths, we've got to think in those other categories as well and move beyond our traditional approach to birthing facilities. And so AIM CCI is doing that in 7 pilot sites across the country as we speak. We also have resources that provide infrastructure at the state and national level for our partners to do this work. We're excited that in 2019, we launched our State Maternal Health Innovation, or MHI grants. Currently, these are in 9 states. They are focused on setting up maternal health task forces, developing strategic plans that are unique to that state based on their particular data related to maternal health, and then operationalizing those plans. And then we are super excited to be partnering with UNC on the Maternal Health Learning and Innovation Center to really be this national hub for acceleration and innovation and supporting our partners across our maternal health portfolio as we move this work forward. AIM is one of the programs that we've had in place for a while now. Our goal is ultimately to have AIM in all 50 states. We currently have AIM in 41 states plus DC, and we've got just under 2,000 birthing facilities participating across the country. Just in the last year, we've increased facility participation by 46%, and we've increased the number of states that are participating by 27%. We're particularly excited that Alabama and Delaware and Kentucky and Nevada and the District of Columbia are now on board. And as you can see on the map, we've got a handful of states left to go, but we are confident that we will bring them on board as well. AIM is about implementing these safety bundles in birthing facilities, and just wanted to share a few success stories from your colleagues across the country. In these states, typically the folks that are working on AIM are working with or through a perinatal quality collaborative. In Maryland, for example, that state collaborative implemented the bundle aimed at safe reduction of primary cesarean birth and saw a decrease in their cesarean birth rate from 30.1% to 27.8%. In Illinois, they looked and recognized they had opportunities to think about people with opioid use disorder, and they implemented the bundle around obstetric care for patients with opioid use disorder. What they were able to do through that was to see an increase in validated screening for opioid use disorder, going from just 3% all the way up to 85%. Connecting patients to medication-assisted treatment at the time of discharge from under half of patients, 41%, to almost 2/3, 67%. And then linking patients to recovery treatment services, again, under half, about 48%, to nearly 3/4, 71%, over the course of the 3 years of this project. And then finally, our colleagues in Louisiana recognized that hypertension was a challenge for them when they looked at their maternal morbidity and mortality data. So they implemented the severe hypertension and pregnancy bundle there. And among birthing persons with hypertension, they were able to see decreases, overall reducing that by about 23%. Among non-Hispanic Black women, a decrease of 8%, and 45% among non-Hispanic white women. This example goes to show that across the country, we have additional and important work to do to eliminate disparities and achieve health equity. So many states are able to claim these kinds of success stories. Wanted to acknowledge these three and the good work that's happening in AIM across the country. We've also seen progress across a variety of the other investments that I talked about in the beginning. And so one of the key features of this work has been collaboration. In the last year, we've seen the launch of AIM bundle interest groups that are coming together to share best practices and success stories across states. That group is relatively new, or those groups, I should say, are relatively new, but they've had 9 calls to date with over 200 participants. We've seen cross-training programs pop up across our state maternal health innovation grantees, and all 9 of our state MHI grantees have stood up task forces since the start of their grant. Across the portfolio, we're also seeing a lot of innovation. We're seeing partnerships with folks like home visitors and WIC program staff, engaging them in training on maternal early warning signs and giving them the tools to recognize that in their clients and be able to connect them with community resources. We've seen the launch of the National Maternal Health Resource Center, which came online with over 160 different resources available, and to date has had nearly 24,000 users. We've seen states engage practitioners in obstetrical simulations to help them better prepare for cases that may lead to morbidity or mortality in the hopes of preventing those. And we've seen new care models launched, for example, 2-generation clinics that provide care for both pregnant women and their infants. And finally, we've seen a lot of work around data enhancement, thinking about states enhance their efforts at surveillance and maximizing use of existing data sets. So for example, in New Jersey, they merged their birth data from vital records in their hospital discharge data to be able to create an analytic data file. In Maryland, they've stood up a pilot program in hospitals to be able to conduct surveillance for severe maternal morbidity and then to merge that into a review of those cases. So a lot of exciting work happening in these areas of collaboration, innovation, and data enhancement across the portfolio. There is also, very excited to say, a focus on equity across our investments and truly across HRSA, across the Department of HHS, and across the Biden-Harris administration. So as many of you know, at the beginning of the administration, there was a new executive order on advancing racial equity and support for underserved communities through the federal government. That executive order reached across federal agencies, and so certainly HRSA and the Maternal and Child Health Bureau are impacted. It aligns well with the work that we do and the focus on equity that we have. On the right-hand side of the screen, you'll see our brand new strategic plan and our 4 key goal areas. And I've outlined here, one of those 4 is focused on achieving health equity for MCH populations. So that has been an area of focus for us. It will become an area of even more increased focus moving forward. And we will be excited to share that work with you as partners as we continue to move ahead. Certainly, it's important to acknowledge the work that's going on related to COVID-19. And we know that many of you are involved in your communities and your states as part of the response. We know that pregnant and recently pregnant people are at increased risk for severe illness from COVID-19. And we've also seen over the course of the last year and a half, increased incidence of depression and anxiety, post-traumatic stress and loneliness among pregnant and postpartum women. So as we're thinking about our response, being very mindful that we don't just limit on treating the very obvious complications of the infection, but that we also think about whole person approaches and think about mental and behavioral health as part of our response as well. In response to the pandemic, the Maternal and Child Health Bureau has partnered with grantees across the country in a variety of ways. Last year, we received $15 million to support telehealth efforts across a variety of MCH populations. We awarded $4 million of that to the University of North Carolina at Chapel Hill for the Maternal Telehealth Access Project. Really thinking about how do we increase telehealth access and infrastructure, both for providers and for families, and to do that while thinking about improving access and improving quality of care, including mental health care during the pandemic. So we are grateful for the partnership with UNC and the tremendous work they did. They've partnered with a variety of folks and including organizations that have not always been at the table to really help us think about how we move this work forward in an equitable way. We also know that our grantees have been very involved in this response. Just want to share a couple of examples. In Ohio, folks there have been using their maternal and child health block grant funds and a mix of state funds to think about identifying and tracking COVID cases, particularly during pregnancy, going back and being able to link those to birth and death certificates, and utilizing the data they get from that to improve service delivery in their states. Similarly, in Oklahoma, they've used maternal and child health funds to track the impact of COVID on pregnant women and infants. They've used some of our MCH block grant resources to do contact tracing and testing, to do work to complete case reporting, and then to be able to provide some of that data support for record abstraction. So we are glad that our funds are flexible and can be used in this way, and really appreciate the ways that states and jurisdictions are using our investments to advance this work and improve the health of women and infants. One key opportunity that we want to flag moving forward is this opportunity to really promote COVID-19 vaccination. So we know now that COVID-19 vaccines are available for all people 12 years of age and older. And specifically, that includes people who are pregnant, breastfeeding, trying to get pregnant now, or might become pregnant in the future. As you all know, that recommendation has become even more solid in the last month or so. And so we want to encourage all of you to help get the word out and encourage anyone who falls in that 12 and older bucket, particularly people who are pregnant, breastfeeding, trying to get pregnant, or might become pregnant in the future, to get vaccinated. If folks have questions, we do have an MCHB funded resource through Mother to Baby. They can answer questions via chat or on the phone, and you see both their website there as well as their phone number, and they are taking calls. The calls to those lines have increased over time, and we would encourage you to share that resource with your community partners. I want to close by sort of reminding us why we are here, and that is to improve the health and well-being of America's mothers, children, and families. And when we think about maternal health, we know we have such an urgent need to accelerate our pace of change. The Bureau has been in this space for a long time. My predecessor actually penned a forward to a report. You can see that on the right-hand side of your screen. And some of the key messages from that report are maternal mortality is in great measure preventable. We're not seeing declines in recent years in the United States, and other countries fare better than the United States. The striking thing about this report to me is that it was written in 1916. If you just read the highlights, it sounds like it could have been written last year. But 105 years ago, our colleagues were having this same conversation that we have today. I encourage you and implore you to make sure that the colleagues who come after us in 105 years are not having this same conversation. We've got an opportunity to have a very deliberate focus on equity. We've got an opportunity to build the workforce to meet the needs of maternal health in this country. We've got an opportunity to innovate in care delivery, to improve the quality of care, and to hold ourselves accountable. We are confident that all of us collectively working together are up to the task, but we have to act on it. We have a window, we have support. We really need to move this work forward. So I hope you feel the urgency of this moment as we do. We so appreciate your partnership and want to celebrate all the work that's been done to date and really recognize all the work that we have to do moving forward. We commit to partnering with you on that, and we look forward to that journey together. Thank you.
Thank you so much, Dr. Warren. That was a great charge and kickoff to our two-day meeting. And hopefully we're not looking back in 100 years and challenged by the same problems. So at this time, I'm going to transition us to our panel, our first panel of the program. But I want to just give you a brief overview of our virtual platform and some highlights from our agenda. And I want to make sure that you are seeing me. Yes. Okay, so over today and tomorrow, you will hear from several diverse speakers who are working at local, state, and national levels, sharing their perspectives and their experiences on maternal health. We will have 5 general sessions that are going to be in the main room, and 3 blocks of time will be for concurrent workshops. So you'll be able to choose which sessions you'd like to attend. You can access all the connecting information under the Schedule tab in the Chime platform. So Chime has everything that you need to identify which sessions, the speakers' bios, and any networking opportunities. We also have a graphic recorder. We're very excited who will be drawing during our sessions and amplifying points from the various presentations. And you can learn more about her in Chime as well. And hopefully we'll get to see some of her work throughout the 2 days. A logistical note about questions during sessions. On the Chime platform, there are 2 tabs. One is day 1 Q&A and one is day 2 Q&A. If you have questions, please go to the relevant Q&A tab. We have so much great content. We may not get to every question, but we will have a forum tab so you can participate in discussion boards with other attendees. And we'll be monitoring the questions. Most of the content that we're providing to you today and tomorrow is live. And while we have tried to plan for any connectivity issues, we know that this is a virtual space and we may have unexpected challenges. If we have any technical difficulties, we will send an email as soon as we can to let you know what's going on and how you can reconnect. But fingers crossed that we're not going to have any issues. So now I'd like to introduce our first panel. As I said earlier, we were planning to have a hybrid session with an in-person opportunity in Baltimore, Maryland, and we were going to introduce you to Baltimore through this session because there is so much great local work happening in Baltimore. However, as Dr. Warren said, the Delta variant disrupted our travel plans, but we still know that the panel of advocates that you are about to hear from have powerful stories to tell and will describe their work at the local level and how they are advancing maternal health in their communities. I'm going to introduce Dr. David Fakuhnle, and then I'll have him introduce the panel. And I think some of you may have had the privilege of seeing Dr. Fakuhnle in some of our other webinars that we've offered through the Maternal Health Center. He is an adjunct assistant professor at the University of Florida and associate faculty in the department at the Bloomberg School of Public Health, the mental health department. He's particularly interested in the built environment, so societal manifestations of racism, and has focused on how to strengthen health, equity, and ultimately liberation. He's also artistic. He uses stories and culture, African drumming, singing, and theater to communicate messages. So we're really excited that he's with us again today, and I'm going to turn it over to you, Dr. Fakuhnle. Thank you.
Right on, right on. Thank you so much, Dorothy. It's a pleasure to be here virtually. I would rather much be downtown, but my office ain't too bad. All right. So grateful to have this opportunity to introduce two incredible Black women who are champions for the womb. I'm honored to be part of an organization called Womb Work Productions, and it's about all the beauty, all the joy, all the work that starts in the womb. And these two sisters know that better than anybody else. So I'm going to shut up. I'm going to just say, please give a warm welcome to Miss Anna Temple Rodney, and please give a warm welcome to Miss Teneele Bailey. Sisters, it's such a pleasure to have you here. Thank you both for being here. So how I want to start is by giving you the floor and letting you all tell your story. That is the best way for us to ground this conversation, to learn about how maternal health is being conceptualized in Baltimore, how it's being operationalized in Baltimore, and what are the explorations that still need to happen and are happening in real time in the city of Baltimore. So with that said, who would like to go first? Anna, you want to go first?
We're both Aries, so I don't know how we're going to do this. We should have talked about it.
I would flip a coin, but I saw Anna unmute her mic first.
She did go
so
first.
that
That's
already
true.
told me.
I mean, I was just unmuting my mic to say hello, to greet back, but that's fine. We can go with it.
All right, you can go first.
I was not being presumptuous, I promise.
It's all good. It's all good.
So I just want to give a quick caveat to our audience. I, too, was really looking forward to meeting in person, mainly because I have a 5-month-old and a 6-month-old in my home. So if either one of them busts in the door, you're going to have to give me some grace because I missed my opportunity to get out of the house with you all.
It's maternal health, though. That's part of the health.
It was part of my self-care to get out of the house. And I work in self-care, and my self-care was great. I'm going to get out of the house and talk to some adults. Now I'm in my room/office talking to adults on the computer, and that's fine. Here we go. All right. So, again, thank you for having me. My name is Anna Rodney. Some people who've known me longer know me as Temple. If you can't say Anna, you can call me Temple. That's fine. And I am the executive director of Mom Cares. And Mom Cares is an organization that works specifically with Black women in Baltimore City, supporting their birth outcomes. Mainly, we started our work with Black women who had traumatic birth stories and birth outcomes, and we'll talk a little bit about that in just a second. But recently, we have been able to we were focused on postpartum in the beginning, and we've been able to expand to birth as well, and hopefully soon, we'll talk about it later, preconception. So I'm not going to read this to you. I know everybody is educated and can read this. I am going to give you the actual background of Mom Cares. So the 6-year-old that we are hoping does not bust into my room, was born at 1 pound and 5 ounces, and that's him in the corner with me. 1 pound and 5 ounces at 28 weeks and 6 days. At the time, I was underemployed and then eventually became unemployed throughout that time. I was Black, overweight, and single, who had dealt with lots of social issues throughout my pregnancy and also had some morbidities. Because of that, in our NICU stay, our 6-month NICU stay, I experienced bias on levels that I never thought that I could withstand. And unfortunately, as I am a doula in the Baltimore community at the time, there were not many people around me who understood how to offer support, especially with something so precarious as a baby in NICU. And so let me go back a little bit. I am a doula. I've been a doula for the last 15 years. I'm a yoga instructor, executive director, herbalist, Reiki master, and probably any other hippie thing you can think of, you can assign to my name. That's who I am. So in 2015, I came out of the hospital with my son and realized that I had gone through a traumatic experience with little to no support and needed real help processing and moving forward. I came out with a diagnosis of PTSD, and also adjustment and anxiety disorder. And I needed help navigating that as I navigated a young child with lots of health needs. After I came home with my son, I realized, okay, we need to process and take some time, but we also need to fix something, because what happened to me and what I saw happening to other families in the NICU as I stayed in the NICU for 6 months was that people weren't getting what they needed. And so we started in 2016 with just a healing circle, which was just an opportunity, again, for self-care to say, okay, we have a babysitter here. You come into this room, we get some massage, get some Reiki, get some acupuncture, and take care of yourself. Have conversations with other mothers about things that are important to you. You know, is the color of my baby's poop, is that normal? What's the color of your baby's poop? Or maybe not even talking about the baby, but having conversations and building community with other people who have gone through traumatic birth experiences. And so that's how we started in 2016. In 2017, thanks to an award from the community, we were able to actually start our organization officially with a fiscal sponsor and start to build out programming. And so since 2017, we have expanded just from healing circles to we have a young mothers program. We offer deliveries in the community. We have doula trainings, and we also provide doula support and a host of other different services that come up as we are interacting with our community and with our clients. Again, I cannot say this enough. The gentleman that was presenting before us was talking about the maternal outcomes and how they have not changed in over 100 years. And so looking at those numbers and understanding how those numbers have not changed, especially for Black people, Black women, Mom Care serves exclusively Black and Black identifying birthing individuals in Baltimore City. Mothers who are high risk, that may need NICU support are prioritized. And we also support Black fathers in the co-parenting relationship and also navigating the trauma of having a baby in NICU. So again, we've kind of talked about what we offer. NICU care, postpartum. So when I say I'm a postpartum doula, if you have any frame of reference for what a postpartum doula does, you would think laundry, helping with lactation, taking care of older children, other things like that. For postpartum in the NICU, those needs are drastically different. And so we offer in the NICU just one-on-one bedside support where we can offer support and just be in the hospital with you by the bedside, hearing your cries, listening to how you're feeling, listening to your frustrations, but also being an advocate and a go-between for medical professionals and the families, because that relationship can kind of get precarious, especially when emotions are high and anxieties are high. We also, at the beginning of the pandemic, we decided rather quickly to start to offer deliveries to families affected financially in the city. And so we offer formula, breastfeeding supplies, cleaning supplies, toilet paper, and all of the other things that you kind of couldn't get your hands on at the beginning of the pandemic. We offer that through delivery for mothers throughout the city, mothers and families. We also have a number of different programs that, again, we mentioned the Young Mothers Program that offers, support in the parenting relationship, talking about co-parenting, intimate partner violence, financial needs, budgeting, and also has a workforce development component in which the young mothers get doula training and support in getting their certification and being placed after their training is over. We continue to do our healing circles. I am very, very proud that our healing circles have withstood the test of time and the pandemic and continue to be a safe space and a space of education at this point for community members and people who are interested in both supporting and being supported in the motherhood and parenting journey. We have recently have the doula trainings that we are giving. We've given 4 doula trainings this year and are hoping to do one more, focused on individuals who are looking to shift their career because of issues in the pandemic, and also people who are just interested in Black maternal health in general. And then we also offer bias training to organizations and hospitals, community organizations, and hospitals who are impacting our families and our participants to make sure that they're taking care of our families and our participants in a way that is appropriate and helpful, and also understanding how racism plays into the care of the community. So we are excited. Where are we at? We are in Baltimore City. We are excited to be able to partner with so many organizations. We couldn't fit them all here on the screen, but University of Maryland Medical Center, Sinai Hospital, New Song Community Learning Center, the Baltimore City Health Department, Family League of Baltimore, and Mount Washington Pediatric Hospital, just to name a few. We serve Baltimore City residents and those who are also being serviced by Baltimore City hospitals in the community and community organizations. We are hopefully going to be expanding within the year to be able to offer services throughout Maryland, but right now we are in Baltimore City and sometimes Baltimore County. With these partnerships and these organizations, we have been able to offer help and support to roughly 500 families from the beginning of our inception to now, and we are hoping to expand that even more as we move forward. So this is our impact. This is what we do. We work in the community, we support, we listen to our community and figure out ways that we can be supportive. We understand that the birthing journey is not in a bubble, and that the birthing journey is, we have to look at that holistically. We have to understand that housing plays a role in how we experience birth. Food security plays a role in how we experience birth. Domestic violence plays a role in how we experience birth. And so it is our duty as a community organization that says that we're serving the community to make sure that our communities are not only experiencing support just within the birthing setting, but also holistically within their entire lives. And so we work very hard to partner with other organizations to make sure our families have what they need. We understand that stress is a big part of health issues in the body. Just as a practitioner, we know that stress can manifest in the body in a number of different ways. And so we make sure that we are helping our families be as stress-free as possible with the things that they have needs for. So that is me. I'm going to just say this final slide I'm very proud of. Last year for Black Maternal Health Week, we were able to create a number of different billboards that went up in the middle of Baltimore City that really showed exactly what it is that we're about, that our organization is about, and asking the community to take note as well. And so I will end in saying that we know that Black maternal health is an issue and has been an issue from the beginning of Black women giving birth in this country. And we know that there is a reason for that. We know that there are compounding issues. And we, as a country, up until recently, have been able to only look at the outliers, the reasons, the things that are happening with us because of what has happened to us, right? And so we talk about, oh well, you're obese and you're not eating right. Okay, but for generations and generations, I've been given the least of the food, and I've had to make do with scraps. That has become a part of my cellular ancestral memory, right? And also I have mental scars that have been passed down through my DNA that I have to navigate through. So I have to understand that, food feels good to me. And so I'm eating food because that is safety. I feel safe. I remember my grandma feeding me, right? So we can't just go in and say, oh, you're obese. You got to stop eating food. You're the reason why your baby is not doing well. You're the reason why you're not doing well. We know that is not the case, no matter how you slice it. And so I'm really looking forward to a conversation. I'm not sure where I'm on time, but I'm really looking forward to a conversation about where we can get deep into these issues that are actually facing our families and making this disparity what it is. And so just to call a spade, racism, institutionalized, deep inset, generational racism is the issue that we are facing. And it is not something that we can fix just because we talked about it once and we feel good and we have a wonderful rainbow coalition of friends and we go out to eat and now everything is fixed. We really have to go about the work of undoing and unraveling ourselves individually and collectively, and then coming back together so that we can do this the right way. Again, birth, a number of maternal outcomes are preventable, largely preventable. And it just means that we need to commit to the work. So I'm imploring everybody that is under the sound of my voice, as you're listening to the conversation, to make sure that you give yourself just an internal commitment to take this conversation past this moment and to really evaluate how you can be part of the change. But I can be reached on all of these platforms. If you put in The Rising Mama or Mom Cares, we pop up, and I'm so grateful to be a part of this panel, and I'm looking forward to hear Teneele.
Absolutely. Thank you, Anna. Appreciate you so much. Teneele, please introduce yourself to our lovely audience.
Good afternoon, everyone. First, before I introduce myself, hand claps and snaps to Anna and her presentation. Thank you so much, sis, for giving us such a wonderful overview of Mom Cares and how Mom Cares is moving throughout the city of Baltimore and affecting change within the city's mamas. My name is Teneele Bailey, and I serve as Maternal Health Coordinator with Baltimore Healthy Start, project team member of the Baltimore Safer Childbirth Cities Initiative, which is funded by Merck for Mothers. I also serve the DMV area as a birth doula, herbalist, yoga instructor, and certified breastfeeding specialist. So some would refer to me as a Jill of many trades, and I'm cool with that. But I would like to go ahead and get right into the presentation that I have for all of you. And in my past life, I worked in higher education So please indulge the teacher in me, and please indulge the slides. So again, I serve as maternal health coordinator with Baltimore Healthy Start. And our slogan, plain and simple, is our babies are more precious than gold. So hopefully with my presentation, I'm going to show you pretty much starting healthy and staying healthy with BHS. So just a little background. I'm actually going to move this so that way I can read my slides here. So basically, with Baltimore Healthy Start, we work with our families in their residences and communities to ensure that every child has a safe, nurturing, thriving environment every day for the first few years of life and beyond. So very simply, our mission statement is that Baltimore Healthy Start Incorporated is committed to reducing infant mortality by utilizing a life course perspective for improving the health and well-being of women and their families through the provision of comprehensive supportive services offered in the communities where they live. So who's Baltimore Healthy Start? So we were established in 1991 as a 501c3 nonprofit corporation. We're one of the original 15 Healthy Start projects. Also, the only federally funded program of its kind in Maryland. We're a member of Maryland Nonprofits, and we are also a Be More for Healthy Babies partner. So when it comes to reducing disparities in perinatal health, the Healthy Start Initiative states eliminating disparities in perinatal health is a service delivery model that uses evidence-based practices, standardized approaches, and continuous quality improvement to achieve Healthy Start benchmarks. Successful service delivery mode integrate and coordinate community-based and Healthy Start services to provide holistic and comprehensive services to achieve optimal health outcomes for all participants. In a nutshell, the title of my presentation gives you the feel of all of this, as far as we want our families, we want our babies to start healthy and to stay healthy. So our direct services team consists of recruiters, neighborhood health advocates, case managers, certified registered nurse practitioner, a high-risk nurse, clinical community health workers, early childhood development advocates, and last but certainly not least, and I do not say this mildly, our fatherhood engagement specialists, because sometimes when we're talking about maternal and child health, our men, the fathers, they can get lost in the sauce, and sometimes they can be taken out of the conversation. And at Baltimore Healthy Start, we involve the fathers, we include them in the conversation, and we remind them of the pivotal role that they play within mama's health and within the health of their children. So where we are. So we work in communities with rates of infant mortality of at least 1.5 times the US national average, and high rates for other adverse perinatal outcomes, such as low birth weight, preterm birth, maternity morbidity, and mortality, okay? In order to address the needs of high-risk women and their families before, during, and after pregnancy. So some of the communities that are served include Sandtown, Winchester, Rosemont, Edmondson Village, Garrison, Middle East, Greater Greenmount, and Morrell Park. And Baltimore Healthy Start, we operate from our main office, which is located at 610 North Chester Street in Baltimore, Maryland. So the 4 approaches that guide the work that we do. Number 1, we want to improve women's health. Number 2, we want to improve family health and wellness. 3, we want to promote systems change. And 4, assure impact and effectiveness through workforce development, data collection, quality improvement, performance monitoring, and evaluation. With regards to who we serve, in order to be eligible for enrollment in the home visiting program, you have to be pregnant or be a woman with a child 6 months or younger, or be the father to an expectant woman's unborn child, or be the father/partner to a family in the program, and live within the service area that I covered in the previous slide. Once enrolled, we follow families until the baby turns 18 months old. So the fun part, what we do. So you can divide what we do into two main categories. As far as core client services of population health, there's outreach and participant recruitment, case management and care coordination, which is housed under the umbrella of our home visiting, health education, maternal depression screening and referral, interconception care, developmental screenings and referrals, and STI screening and pregnancy testing. With regards to family engagement and wellness activities, we have belly buddies, breastfeeding education and peer counselors. And speaking of breastfeeding, big ups to the month of August being National Global Breastfeeding Awareness Month. And for this very special week, this special time of August 25th to August 31st, annually since 2013 being designated as Black Breastfeeding Week. Also within family engagement and wellness activities, we have GED classes. Well, we offer GED classes rather. There's a food pantry housed at our main site, emergency diapers, formula, cribs. And in times of COVID, Baltimore Healthy Start has had to shift to a remote service delivery model. So a lot of what we would normally do with regards to outreach, home visiting, and providing items and resources to our families have been switched over to remote service. And we developed an emergency response team that has been going out into the community served with items that folks need during the pandemic, such as diapers, formula, wipes, prenatal vitamins, any items at pack and plays, any items that they may need before, during, or after pregnancy. Also, the Healthy Start store, early childhood development program, our fatherhood services, pregnancy testing, family planning with the certified nurse practitioner, teen group, and also our Circle of Security parenting classes for which we provide transportation. So who do we work with? As far as the overview of Healthy Start, this is just a fraction of the individuals that we work with in the city of Baltimore. When I go over briefly our work with Merck for Mothers, you'll see how this network of who we work with has expanded since being a grantee of the Merck for Mothers Safer Childbirth Cities initiative. However, at our core, we work with Total Health Care, Be More for Healthy Babies, which is a citywide strategy, University of Maryland with the We Care to Coordinate, Maryland Birth Network, Kaiser Permanente, Barbershop and Beauty Salon Initiative, which is how we get information out into the community and basically meeting folks where they are, i.e. the barbershops and the beauty salons. O-Taste Lactation and Baltimore City Community College. We're able to partner with numerous other agencies through care coordination, referrals, and also our Community Action Network, or CAN for short. And how do we collaborate? So obviously, we collaborate through Be More for Healthy Babies. Also, our Baltimore Healthy Start Community Action Network, which 25% of the network is comprised of residents of the city of Baltimore. So this is how we're getting feedback from the community as far as what the concerns are, what the needs are, and how to best address those needs and those concerns. We also work closely with and collaborate with the Mayor's Office, Maryland Breastfeeding Coalition, and any community organization that wants to work with us, especially if they're neighborhood-based. So now I'm going to kind of switch gears a little bit and go over our work with Work for Mothers. So the Work for Mothers Safer Childbirth Cities initiative, it aims to support community-based leaders in U.S. cities with a high burden of maternal mortality and morbidity to implement evidence-based interventions and innovative approaches to reverse the country's maternal health trends. Long story short, we want to take that 100-year scenario and reverse that. So the Baltimore Safer Childbirth Cities initiative, this is just a brief overview. Again, BHS received the Work for Mothers Safer Childbirth Cities grant in September of 2019 and endeavors to address and improve maternal health outcomes through 5 project aims, which cover the areas of citywide surveillance, quality improvement, direct service, and sustainability. The 5 main project points are augment the state of Maryland's maternal mortality review process with a Baltimore-focused severe maternal morbidity review process, implement a Patients as Partners initiative to bring the knowledge and experience of maternity patients to bear on hospital and health system quality improvement processes, implement a maternal health monitoring intervention, or MHMI for short, of prenatal and postpartum home-based assessments for BHS clients with immediate medical referral if indicated, provide postpartum care services that are delivered by certified registered nurse practitioners. They're co-located and co-scheduled in FQHC pediatric clinics at 2-week, 4-week, 2-month, 4-month, 6-month, and 12-month infant well child visits. And lastly, what any organization seeks to do, seeking funding to develop and support other evidence-based maternal health direct services and patient-centered maternal health research initiatives, because we want to keep the work going. We don't want to just be a flash in the pan. So as far as our actual initiative, I'm just going to briefly speak on the SMM review process and Patients as Partners. So with regard to severe maternal morbidity, how we identify and review the cases, what events are we reviewing? So for example, we're looking at pregnant, peripartum, or postpartum women receiving 4 or more units of blood products, pregnant, peripartum, or postpartum women who are admitted to an ICU as identified by the birth facility, and also other pregnant, peripartum, or postpartum women who have an unexpected and severe medical event at the discretion of the birth facility. Okay, and this is per the CDC. So one thing to come out of this is the formation of the Baltimore City Maternal Mortality Review Committee. So the Baltimore City Health Department, I should have updated this from being is currently to it exists now. We have an MMR committee that is going to review cases of maternal mortality in addition to incidences of severe maternal morbidity. This team is going to collaborate with the state and community partners to identify gaps in local systems, recommend strategies tailored to local needs, and work with community partners to implement those recommendations. The Baltimore City MMR team aims to understand local systems issues contributing to preventable maternal mortality, emphasis on the word preventable. There's absolutely no reason why Black moms should be dying at 3 to 4 times the rate of our counterparts, or encountering close misses or close events. Okay. Secondly, narrow racial disparities and promote racial equity in maternal health and the factors that contribute to it. Develop evidence-based and locally relevant recommendations to prevent maternal mortality and promote maternal health. And lastly, work with city agencies and community partners to implement recommendations, including changes within local systems and agencies. The Baltimore City MMR team will be comprised of health providers, prevention practitioners, community leaders, and advocates from across the city. Individuals were selected based on a combination of expertise, commitment, and the perspectives they represent. It was very important to have folks with lived experience on the MMR committee.
All selected individuals were then appointed by the Baltimore City Health Commissioner. So the purpose of SMM review, more specifically, Baltimore-focused SMM review, we want to identify and understand the contributing factors of severe maternal morbidity in order to, there's that word again, prevent injuries that lead to mortality. Also highlight opportunities and make recommendations for improvement in care in order to prevent future incidents of severe morbidity and mortality. And just a little footnote here, the experience of Baltimore's Fetal Infant Mortality Review, or FEMR for short, demonstrates the value of patient accounts in identifying clinical and system issues for improvement. So amplifying the voices of our patients is paramount. When it comes to SMM, these are some of our partners: the Baltimore City Health Department, Johns Hopkins University's MD Mom, the Maryland Maternal Health Innovation Program, also the Maryland Department of Health, the Maryland State Medical Society, or MedChi for short, and the Maryland Hospital Association. So as far as patients as partners, and this has a special place in my heart because it focuses specifically on amplifying the voices of patients and also medical narratives or storytelling amongst the patients. So in partnership with the Preeclampsia Foundation, Patients as Partners is an effort to learn from women who have recently had a baby, specifically about their experiences and interactions with the healthcare system in order to improve the quality of maternity care in the city of Baltimore. So Patients as, it's a tongue twister, Patients as Partners, the project includes focus groups to understand the experience of birthing women at Baltimore City hospitals, patient advocacy training of focus group participants, and patient forums where patients will share their stories in real time with hospitals in an effort to work as partners to improve quality. I'm happy to say that we've had this round of focus group participants who are involved in the focus groups this past spring have completed their patient advocacy training this past Saturday. So they'll be moving on to serve as a panelist for our upcoming maternity care forum, which will be happening at the end of next month. So the purpose of Patients as Partners is to understand the birth experiences of women in the Baltimore community in an effort to improve outcomes in maternal and newborn care. And the way that I'll close this out is simply by saying the overarching goal of efforts by those doing the work of Black maternal and child health promotion, reproductive justice, and birth equity is achieving maternity care that is equitable, solution-focused, driven by community, and void of discriminatory practices, obstetrical violence and neglect, and systemic racism.
Wonderful. Awesome. Thank you, Teneele. Appreciate you so much. That was wonderful grounding to the work that you both do around maternal health. I like to say almost parental health. Is it okay if I say parental health?
Yes.
Yeah, I'll say parental health, and I really appreciate the acknowledgement of the importance of fathers. As a father myself, I wanted to do the best I could, for my wife as she was going through the birth of our son, and I think there was a lot more I could have learned during that process, and having a space where. And I thought I was okay. No, don't get me wrong. I'm never going to put myself in a situation of the circumstances of others. But just knowing there was a space where just my thoughts and my feelings about this whole new journey I was taking as a father is greatly appreciated. And I speak for all the fathers out there. Thank you for creating these spaces where our voices and our feelings it's all good, Anna. It's okay. It's real time. can be acknowledged. One of the things that I want us to start with, and we have some questions, and I'll definitely get to the questions from our audience. You both mentioned the work that you do as doulas, as just in capturing all these other aspects and nuances of the birthing process, not just the birthing process, but before birth, during birth, after birth. I'm a huge proponent of culture, as you all know. So please just elaborate on, I would say, the necessity, not just the importance, but the necessity of culture around birth, before birth, during birth, and after birth. How does that make a difference so that people really understand this cultural aspect? And I'll preface by saying this. So from a public health standpoint, we are in the fifth wave of public health, and the fifth wave of public health speaks specifically to the importance of culture. So what is it about our traditions? What is it about our practices? What is it about our connection with our people, however you define our people, that makes a difference in our health and well-being? And you both have given examples of that. So really, I just want our audience to truly understand and truly appreciate the importance of our culture as it pertains to our birthing process. So whoever wants to go first with that, please do, because that's just critically important. I can't let that slide.
So I'll touch on it briefly, and something that just literally came to mind. So I feel that culture pretty much lends a hand to compliance. And by compliance, I'm talking about if you're a woman who finds herself pregnant, or even thinking about getting pregnant, trying to get there, or in the postpartum period, so perinatally, you're going to identify with healthcare providers, community birth workers, other individuals in this space. You're going to identify with folks that not only look like you, but can also relate to the experiences that you are encountering during your journey, and not just the pregnancy portion of it, but also the social aspects that you are experiencing day to day. Microaggressions that come with interacting with the healthcare system. So culture, we know that culture is important because it gives us a means for identification. It gives us a means for belonging, place, confirmation, all these things. But it definitely, to me, it just makes the experience more worthwhile, more sacred, and I think that there's more value as well when you're working with individuals that just share your culture and just share your experiences and share your lived experiences.
Thank you.
Absolutely. Yeah. And to add to that, there are a number of things that are happening in my head right now. So first, I think understanding culture in the setting that is the United States of America, right? And so all of the things that were actually set up for us, like the fact that we have the lowest instances of breastfeeding initiation in the country, but 100 years ago, when we were talking about maternal health, one of the main roles of the Black woman, especially in slavery and antebellum slavery, was a wet nurse. And so lactating for our children and other people's children is inset in us. Somewhere along that line, things were flipped intentionally. And so we have kind of lost that. And so understanding culture for me means knowing how to interact with mom's mom, grandmom, who's like, don't get that baby formula. I gave you formula, everything's fine. Understanding how to have that conversation in a nuanced and respectful way so that you're sending mom home with support. And not just kind of saying, here's how to do it. Good luck. See you later. Like, you're actually addressing the entire family unit. You're addressing the support system. You're addressing the partner. You're addressing those people that are going to be surrounding that mother in that postpartum period to provide support, and understand how and some of the pitfalls that history has provided for us, so that we are not as successful at certain outcomes associated with birth. So I want to say that, number one, but also having someone in your corner who looks like you and identifies with you. Something that I take very seriously is that I am not a code switcher. Who I am is who I am, right? But understanding that when I go into the hospital setting and I'm making a joke with my provider and I say something like, "Ain't nobody got time for that," that creates a bias potentially, right? Like somebody's like, okay, if the nurse is like, okay, we're going to take your blood. And I say, "Ain't nobody got time for that. I don't want to do that." I know that I'm joking. I know that I'm educated, but that language, that tone automatically steals some respect. It steals some regard. It steals some assumption of my education and my knowledge, right? And so being in a setting with someone who you can communicate with and you don't necessarily have to worry about code switching and the like. I feel like I should probably unpack what code switching is, but I'll let David do that because that's the job. I'll let you do that.
And Anna, you brought up a really good point. If I can just very quickly add, we're unfortunately in a generation without grandmothers, and it makes me think of that quote, when a griot dies, a library burns to the ground. So when it comes to just the whole experience of pregnancy and everything about welcoming spirit home, and when I say welcoming spirit home, I'm talking about childbirth. We're missing that support, that element of storytelling and just passing knowledge and wisdom down from our elders. So, from our aunties, from our great aunties, from our grandmothers and great grands. So, it saddens me that we're seeing a generation that is, that's growing up with the absence of grandparents. Both of my grandmothers, unfortunately have transitioned. Both of my grandfathers have transitioned. So when the time comes for me to bear a child, who I'm going to lean on my mom, God willing that she's still here with us. But, it really makes me wonder, who am I going to lean on for support and just for that, just that outpouring of motherly wisdom.
Right. And
No, yeah, go ahead.
I just wanted to add just a quick example of what we're talking about personally, because I do have an infant, and I had a doula, a postpartum doula, who is a good friend, a wonderful colleague, someone that I've known for years, who is Caucasian. And so my entire birth team, everybody was Black, all Black, everything. But my doula was my postpartum doula was Caucasian. And so as she watched me putting together some herbs that I saw someone put together, where I've heard someone instruct me, okay, well, when you need this is what you do. And I had to have a repeat C-section. And so I put together some herbs and I made a salve and put it on my incision. And her first reaction was, "I don't think you should do that. You're going to get it infected." And I had to explain to her, no, like this is healing medicine. This is what we do. And so although again, I love the experience of having a postpartum doula. I, care very deeply for my friend who stood in the gap for me in that way. But having someone who I don't have to explain myself to, who has a shared understanding of, okay, I might not know this, but Anna's grandma from Trinidad said to do this. So because my grandma from Alabama said to do that. So there's a shared experience there.
Absolutely. So what I wanted to get back to what Teneele said really quickly, just about our elders and our elders transitioning without capturing their wisdom, specifically our grandmas and all that kind of stuff. I can speak to that experience. My maternal grandmother passed away years before I was born. So my mother didn't have that, but she did have a great aunt, my great aunt Charlotte, who took that role. So how are you all navigating that? Are you exploring ways to capture the wisdom and insight of the elders, particularly the mamas who have gone through this experience as mamas, as grandmamas, perhaps as great grandmamas, so that wisdom, those insight and those nuances that may not necessarily be captured in the books, may not be captured in the manuals, you know what I'm talking about, to pass that along to this generation and the future generations to come?
If it's okay, I'll jump on top of that. So I, this is me, guys. So I would say that the work that I would say that as a practitioner, a holistic practitioner, I am watching other colleagues and friends and people that are close to me return home, right? So in that gap, in that absence, there is still that yearning, there is still that desire. And so what do? As a people, we go searching and we find it and we create it, we recreate it. And I think that's part of the resilience of Black people in this country. You can cut the root off. And we still grow back. We grow back stronger. So I think number one, that's something that I'm actually witnessing. People saying, "Hey, I want to take a herbalism class. Hey, I want to like a returning, and not just a returning to the things that we had even before we got here, and a desire and a hunger to incorporate those things into the work." Something that I'm very excited to be attempting to do is we talk about evidence-based practices. And for me, sometimes evidence-based practices can be a dog whistle for cultural practices, because if it's not evidence-based, if it hasn't been tested, then it's not good. But we know that every time I got sick, Grandma put me in a soup. She put me in a bath with some onions and some garlic, and she made me take some honey. And that works for me and my family, right? But that's not evidence-based. And so while evidence-based is very important in a very important space, something that we're looking forward to doing is taking some of these tools that are in that medicine cabinet that we have been able to hold on to, and creating work and research around making it evidence-based. Okay, you want the herbs to be evidence-based? Let's go ahead and do that. Okay. So number one, that, but then also just gathering together. Like there's a lot of things that that we can share that nobody is telling each other. You know, like people are suffering with postpartum depression, and they're like, "Oh, I'm fine. I'm getting better," and that's all you talk about. People have questions, and every birth is different, and so people feeling that, "Oh, I've already had a baby, so I should know this." But gathering people together, having community, and of course it's hard right now because of the pandemic, but having community, I think is where we do that, and encouraging those elders who are still with us to engage in that community, I think is the most important.
Absolutely. So thank you for that. I appreciate that so much. There's so much I would love to go into, but being mindful of time, I want to honor the questions that we're getting from our audience. So I will first start with a question from Lynn Ingram McFarland. Thank you, Lynn, for your question. The question is, what screening tools are being used? There are some examples that were provided: EPDS, PHQ-9, and then a subsequent question is, do you find them sufficient for families of color?
So I do know with Baltimore Healthy Start, we do the depression screening, one of them being the Zung screening, and we're obviously looking for ACEs and scoring the clients accordingly. Now, do I think it's sufficient? I'm going to say to a degree, and the only reason why I'm not going to say 100% is because I don't think that there's a screening tool or method that has been created to capture the totality of what Black women, Black families, Black men experience and encounter across the life course.
Great. Thank you, Teneele, for that. Another question from Alice. Thank you, Alice. What are some ways that you made sure people with lived experience were involved in the Baltimore Review Committee? And how does the committee go about making sure that the committee is accessible for people to participate? So, Teneele, I believe that's for you.
Yeah, and Anna can chime in on this as well. So I was involved myself and also our deputy director, Ms. Maxine Reed Vance, and individuals from the Baltimore City Health Department. We were involved in the interviewing process for the Maternal Mortality Review Committee. So based on the interview questions and just how each of the applicants were scored, we were intent on specific areas such as implicit bias, lived experience, policy work, just things that are very instrumental in the work of maternal and child health, and also the review of mortality and morbidity cases. So just being involved in the interviewing process and being able to have conversations as a group, determining the level of lived experience versus kind of leaning on things as kind of like a fly on the wall, almost, for lack of a better way of putting it, the whole, oh, I have Black friends type of vibe. We didn't want any of that. We definitely wanted, folks that were sincere in allyship, and also just amplifying the voices of individuals who are hardest hit by mortality and morbidity in the city.
Great. Anna, you want to add anything?
No, she said it fine.
Okay.
She said it just right. You doing a good job.
Right on. Okay, really quickly, we got about 4 minutes left, and we have one more question, and this question comes from Karen Clark. How do you suggest medical professionals evaluate and support the practices that that you all have discussed and introduced us to this afternoon? I am sure they are helpful and not harmful, but we are taught to follow, again, that dog whistle you talked about, Anna, evidence-based practice. So that's perfect, because that was a question that I want to end us on. I believe in science. I also believe in the culture. How do we find the balance? That's really the question I'm getting at.
So for me, I work pretty closely with medical professionals, and what I find is that there is this overarching blanket that we want to put on everybody. Mm-hmm. And so you kind of have to step back and understand that everybody is not the same. And of course, when you're talking about service delivery, especially in a place like a hospital, you want things that apply to most and work quickly, right? But we have to understand that that's not the best for outcomes, that the numbers that you're chasing after are not the humans that you're actually working with. And so I think that again, evidence-based is necessary, and evidence-based can save lives. It helps people from making really uninformed decisions. But understanding that something that is not necessarily evidence-based does not mean that it's wrong. And so on my chart, right, it says you have a doctor's appointment, you got 5 minutes with that doctor, right? I could not give you my history or my questions or even start to feel comfortable or build trust with you in a 5-minute time frame. That's enough for you to take my blood pressure, ask me how I'm doing, and send me on my way. And so we really have to be able to find innovative ways to put the human back in the work. And I think that means partnering. Like, you're a medical professional, that's what you were trained to do. There needs to be a more open door to partner with grassroots organizations that are in the community that have their finger on the pulse of what is needed to make sure that those people are being incorporated into service delivery.
Oh, wonderful.
Absolutely. Put names on the numbers, put faces on the facts, and identify the data.
Absolutely. And I think that goes perfectly to the last question from Allison, which was about bridging academic and non-academic communities. So I think exactly what you said, Teneele, is right. Tell the story, tell the whole story. The data, a lot of our quant data will give us the who, the what, the where, the when, but the stories give us the how and the why. And those are the questions that can make the difference. So with that, we are out of time. Anna and Teneele, what can I say? This was awesome. Really quickly, code switching. Code switching is changing your language. So think about the interview language. So the way you talk in an interview, very proper. You make sure you dot all your T's, dot all your I's, cross all your T's. And then when you're in the company of friends and family, very loose, very chill, kind of like how this conversation was. So we weren't code switching in this conversation. We got the information across, but this is the language that we typically speak. But depending on your audience, especially when it's defined by race or by socioeconomic status, you change it up because you want to fit in. Everybody wants to be acknowledged. Everybody wants to fit in. That's just a natural human response. So with that, thank you both. This was incredible. Again, wish we could have did this in person, but I think it was still powerful, still felt the connection, still felt the love. Thank you to our audience. We appreciate you. Please reach out to these wonderful women. They have plethora of knowledge and wisdom and understanding. They are resources. They are repositories. Utilize them. Elevate them. Empower them. Thank you all. Appreciate you. Peace.
Thank you.
Thank you.
Thank you all so much for sharing your stories and for being so authentic and in the way that you talk about these issues. And I do want to just add, the discussion around evidence just underscores the point that really we need to focus on practice-based evidence as much as evidence-based practice. So it's a two-way street. We are now going to transition to a brief break. Depending on where you are, you should take about 15 minutes. We'll return 2:45 Eastern time. There are a number of concurrent workshops that you can choose from. They'll begin promptly at 2:45, go till 3:45, and then we will reconvene on the main stage this afternoon at 4 o'clock. So again, thanks so much for your participation. Enjoy your break, and we'll see you in 15 minutes.